Paul, do you want to start? Perfect. Okay, and I will share my screen with everyone. Thank you for being here. It's December. Happy holidays. Um, this is the December version of the JVS Online Journal Club. For those who are unfamiliar or haven't participated, we do this once a month. It's hosted by two specific institutions. This month we have Cooper and UPMC, and they have chosen two papers from the contemporaneous JVS in the December edition. And so we have the therapeutic anticoagulation after index peripheral endovascular interventions in patients with claudication. We're thrilled to have Dr. Young and Dr. Hinken here, who will be answering questions. And then clinical presentation, outcomes, and threshold for repair by sex in degenerative saccular versus fusiform aneurysms in the descending thoracic or aorta. And we're very thankful to have Dr. Rastogi here along with Dr. Shimmerhorn. Again, this month, the host institutions, Cooper, Dr. Laurel Hastings, is a faculty at Cooper Medical Center, and her second year integrated vascular resident, Dr. Mark Zamella, will be going over the first paper. And then Dr. Fanny Ale Kusan is at UPMC. She is an assistant professor of surgery there. And their resident, Dr. Michaela Lowenkamp, who's a fourth-year vascular surgery resident, will be reviewing the second article. Thrilled again, we always love that authors are willing to join to help us expand on questions from the research itself. Dr. Stan Hinklin, who is a senior associate consultant at Mayo Clinic Rochester, and then Dr. Michael Young, who is the director of the cardiac cath lab, as well as the director of the structural heart program at Dartmouth. For the second article, as I mentioned, Dr. Rastogi, who is very kind to join us at 1 a.m., where he is to go over and answer questions in case Dr. Shimmerhorn does not know the answer. But I think Dr. Shimmerhorn has joined us multiple times, so he knows the format. Finally, we have our two editorial board guests, Dr. Manuel Garcia Toca, who is the chief of vascular surgery at Grady Memorial Hospital. He's an associate professor of surgery at Emory. And then Dr. Elisa Greco, who is a vascular surgeon at St. Michael's. She's the program director for vascular surgery at the University of Toronto, and also the medical director of the vascular lab there. Just a few housekeeping things. We ask that you please stay muted. If you have questions and comments, please enter them in the chat. The moderator may call on you to speak if the question is a little complicated. The event is being recorded for on-demand access. And then, of course, the JVS Online Journal Club will start back up in January 10th at 6 p.m. Central Time. We have our host group, which is USC and Washington University, and we have participants that are all part of the Young Surgeons Committee from the SVS. So I will stop sharing my screen and we will turn everything over to Dr. Hastings.
All right, good evening. Hopefully everyone can see my screen here. Is that coming up as presentation
It is.
now? Great.
Yep, looks good.
I'm Laurel Hastings with Cooper University Hospital. Thanks to Paul and Misty for inviting us to be a part of tonight's online journal club. Our first article that we'll be discussing is therapeutic anticoagulation after index peripheral endovascular interventions in patients with claudication by Drs. Young and Henkin, who are joining us tonight. Obviously, this is a topic that's near and dear to all of our hearts. Peripheral arterial disease is extremely prevalent, affects about 8 to 12 million patients in the US today. And there have been numerous studies that have been looking at different kinds of treatment options, including exercise walking programs, medical therapy, and then various interventions, both endovascular and open. In terms of the endovascular era, the next question that begs to be answered is which long-term medication regimen is best for our patients? Antiplatelet agents have been pretty well studied. The next topic was anticoagulation, which is what we'll be delving into tonight. There have been a couple different studies that have looked at this. First Voyager PAD trial, which looked at aspirin versus rivaroxaban 2.5 BID, finding that combo, plus aspirin, excuse me, finding that combo drug regimen demonstrated lower acute limb ischemia rates, lower major amputation, myocardial infarction, ischemic stroke, or death from cardiovascular causes. Similarly, with the COMPASS trial, that again looked at aspirin versus rivaroxaban 2.5 plus aspirin, finding that that combo regimen again prevented adverse events, particularly stroke and cardiovascular mortality, with less frequent severe bleeding. So the next question that begs to be answered is if 2.5 is good, is more better? And that kind of comes into play with this anticoagulation conundrum. Well, we're searching for the best way to maintain the patency after our interventions while minimizing the risk of major bleeding events in our complex patient population that oftentimes really can't handle that additional hit with these bleeding events. This is done with various anticoagulants, looking at different points along the coagulation cascade. There are limited studies that have been looking at full anticoagulation following peripheral interventions, one of which is the WAVE trial, which was from 2006-7, which looked at warfarin plus antiplatelet, finding that there really was not more effective in preventing major cardiovascular complications than just antiplatelet alone, but very clearly associated with increased rates of life-threatening bleeding. So that brings us to the article at hand tonight. We're looking at this patient population of claudicants, and I'll turn it over to Dr. Zamella, who is our second year vascular integrated resident at Cooper.
Great. Thank you very much for that introduction, Dr. Hastings, and thank you everybody for tuning in and helping organize this. I'll be explaining or talking over this paper, The Therapeutic Anticoagulation After Endovascular Intervention in Patients with Claudication. And I'll start by touching on the background, much of which Dr. Hastings already covered, so I won't spend too much time. But as we all know, peripheral endovascular interventions are becoming more and more common, and there's still no ideal or standard of care post-procedural medication regimen that is, highly recommended or routinely prescribed. Like mentioned, the Compass and Voyager trials looked at PAD Xarelto or 2.5 milligram BID Xarelto dosing in addition to antiplatelet therapy, but there has been no large-scale study looking at full dose anticoagulation after percutaneous or after endovascular interventions. There have been small regional studies that have done full therapeutic anticoagulation studies after endovascular interventions, but again, this hasn't been done on a national or large scale yet. And these smaller studies did find that there were associated major adverse limb events, patency loss, and mortality with this therapeutic anticoagulation. But again, this wasn't generalizable. It was very regional and small sample sizes. So this paper's hypothesis was that patients that underwent endovascular procedures and were for claudication and were prescribed full dose anticoagulation after, specifically warfarin or vitamin K antagonists, would have higher adverse effects compared to no anticoagulation or some different agent. So this study used the VQI database. They looked at patients from 2010 to 2019, and mortality data was obtained through the Social Security Death Index. And here is the flowchart provided in the paper of their inclusion criteria or their exclusion criteria. They ultimately ended with 26,240 patients, down from an initial 147,000 on their initial query. The primary exposure that was looked at in this study was therapeutic anticoagulation after endovascular procedures. And they stratified this by vitamin K antagonists, oral factor Xa inhibitors, oral direct thrombin inhibitors, and other anticoagulation, which I'll touch on a little bit later. And their primary outcomes they looked at were patency loss, major adverse limb events, or MALE, and all-cause mortality. They did have some stratified data looking at effect modifiers such as what artery or level was treated, like iliac versus fempop or tibial. They looked at what discharge antiplatelet therapy the patient was on in addition to pre-op antiplatelet. And they they used the database to figure out which patients were prescribed anticoagulation for the first time after their intervention versus coming in on full dose anticoagulation. And so This paper did a really great job of getting a lot of stratified data. So I'll just kind of hit the high points here. Of the 26,000 patients that met inclusion criteria, they found that about 9% were discharged on full dose anticoagulation, and I list the breakdown down there below. But interestingly, 78% of these 2,394 patients were already on therapeutic anticoagulation preoperatively. So about 22% were actually prescribed full dose anticoagulation from their endovascular procedure. And I'll touch on this a little bit later, but an assumption was made that it was for the endovascular procedure itself. So looking at the major or the primary outcomes, the first of which was loss of patency, at 2-year follow-up, about 6.8% of patients, of all patients of the 26,000 had loss of patency. And then crunching the numbers, they found that vitamin K antagonists were more likely to have loss of patency to a significant degree, whereas oral factor Xa inhibitors were less likely to experience loss of patency. And there were no differences with oral direct thrombin inhibitors compared to no anticoagulation in terms of patency. And they did find that newly prescribed anticoagulation postoperatively was significant for more loss of patency. In terms of major adverse limb events, about 9% had some sort of major adverse limb event at 2-year follow-up. There was no difference with versus without therapeutic anticoagulation on discharge, but of those patients that were on anticoagulation, those that were on vitamin K antagonists were associated with a higher risk to a significant degree. And lastly, mortality. The anticoagulation group had a higher rate of 2-year all-cause mortality, which was significant. And of that group, vitamin K antagonists for therapeutic anticoagulation, along with oral factor Xa inhibitors, were associated with higher risks of all-cause mortality. And here the paper provided a really good kind of summary of what I just spoke about, with a little bit more information on the different types of anticoagulation that were prescribed and their associated primary outcomes of patency loss, major adverse limb events, and mortality. So this paper found, through its retrospective review of the VQI database, found that therapeutic anticoagulation was associated with a higher risk of 2-year all-cause mortality, but there was no significant difference in risk of patency loss or major adverse limb event. But stratifying the patients by the type of anticoagulation they were on, they did find that vitamin K antagonists specifically were associated with higher risks of both patency loss and major adverse limb events. Like I mentioned before, and like Dr. Hastings touched on, there are many other studies that show adverse outcomes in PAD and claudicant patients with anticoagulants. The WAVE trial that was mentioned earlier, and this paper touched on a couple of lit reviews and other studies mentioned here that all similarly found that full dose anticoagulation, specifically vitamin K antagonists after endovascular interventions, led to worse outcomes, and each study kind of focused on a different outcome. And again, none of these were very large scale studies, and so they weren't generalizable, which is something that this paper wanted to address. In terms of limitations of this study, there are a lot of confounding variables. As we all know, the VQI database is great. It has a lot of information, but on the flip side, it doesn't give all the information that we may want from the VQI database. There's selection bias along with it, and that incomplete data. We don't know, for example, exactly why patients that were on therapeutic anticoagulation pre-op were on it to begin with, whether it was AFib or DVT. And then we also don't know exactly the reason for the anticoagulation on discharge. Maybe the patients had some adverse event inpatient, or like a recent DVT, and so they were started on it for that, not necessarily just the endovascular procedure. And so kind of to sum up, patients discharged with therapeutic anticoagulation had an increased rate of 2-year all-cause mortality. regardless of what anticoagulation was used. But those patients that were discharged on vitamin K antagonists had higher rates of patency loss and major adverse limb events for claudicants undergoing endovascular procedures. And although many other studies point to similar conclusions, SVS still does not give any definitive post-procedural recommendations for anticoagulation after endovascular procedures for claudicants due to inadequate evidence. And with that, thank you all for allowing me to review this paper with you, and I look forward to opening it up to questions and discussing with the authors.
Thank you both for that recap and synopsis of the paper. That was excellent. You know, we're always trying to ask or answer the question to anticoagulate or not, or antiplatelet or not. And we're lucky enough to have the authors here today. So maybe I'll start off with a question, and then there's a couple in the chat that I'll go through, and we'll try to keep a time cap on this as well. You know, we did discuss already the Compass trial came out in 2017 and the Voyager trial and came out a couple of years later, but this paper doesn't really address, or how does that fit into this paper and to your findings that you have? Because I know the VQI database doesn't necessarily capture the dose of the anticoagulant, but your time period is up to 2019, so it just kind of hits that time where maybe people were starting to change their practice.
Yeah, it's a great question, and thank you so much for having us. Well, the answer to that question is we don't know. I think that we can really assume that the majority of patients were prescribed full dose anticoagulation. But the answer is, unfortunately, we don't have dosing of any of the medications. And this is where the issue with VQIs, you all very well know, comes into place. We don't have indication for medication. For warfarin, we don't have INRs or time and therapeutic range. For direct oral anticoagulants, we don't have type of anti-10A or of 10A inhibitor, and we don't have dose. So we can't say, even, for example, you know, I don't know what anybody's practice is, but at several different institutions, my colleagues, for example, have prescribed 2.5 BID of Eliquis, you know, a sort of a prophylactic dose of, well, maybe they'll do something, because who knows, you know, or 5 BID. Or so I think that the majority of the dosing that was prescribed, for example, for Xarelto, my guess would be the 20 milligram dose, or lower depending on the renal function, because I think the uptake in 2018 and 2019 is still pretty low. If you take a look at sort of the national uptake of low dose Xarelto, it was very expensive. It was just started to be used, and the Voyager PAD that, you know, was just coming out into place as well too. So my guess is that the numbers with low dose Xarelto are very small in the study, but unfortunately we can't really look at that. And I think that's where the question of, you know, we can't separate apixaban from rivaroxaban here as well. We don't have that information, you know, and we can't even for direct thrombin inhibitors, for example, we can't separate dabigatran from fondaparinux either. So there's obviously some limitations, but we had to take them together because we needed those numbers. But I think that the idea here really, I think, drives the vitamin K hypothesis. Is the vitamin K hypothesis is that we really shouldn't use it unless we really have no choice. And I think that's probably the biggest uptake from this manuscript that I take away personally.
Right, thanks. Okay, with some questions in the chat here. Are there any variables associated with the patients who were started newly on anticoagulation versus the ones that came in on it? I think you kind of touched on it in your discussion a little bit about selection bias, but maybe if you can expand a little bit on that about patient factors or their anatomy, or, you know, are we anticoagulating for our own benefit, hoping that the stent will stay open because there might be a dissection flap or something that we found there?
Yeah, it's a great question, and we don't really discuss that in the manuscript very well. But when we took a look at that, the patient factors that were associated with newly started anticoagulation was most distal disease, so that was usually tibial disease, and the variable of successful revascularization or not. So people who were not successfully revascularized were more likely to be started on new anticoagulation. You know, the one thing I would like to add is, we tried to control for as many variables as we could with inverse probability weighting. So obviously there is still confounding with that we can't control for, but we tried to address it as much as we could with retrospective studies. So technical success, and and that's why we included this, most distal disease studied as an effect modifier, because the anatomy of iliofemoral treatment is very different than treatment of tibial disease. So the answer to that is yes, there are specific factors, and that is why I think if you look at what predicts worse outcomes such as patency loss, it's those who are newly started on anticoagulation, probably because as an interventionalist, there's feeling that the success is more likely to be lower in these patients.
Right. There's a question in the chat again. So why does this data refute the Compass or Voyager trials? Not sure that it does, but maybe I'll let you expand on that. And was there bleeding a significant cause for morbidity or mortality?
Yeah, so as you know, there is no great variable for bleeding besides postoperative bleeding, which we didn't take a look at. But when you look at mortality, we don't have cause of mortality, for example, so we don't know. And the answer is probably that's why there's such poor outcomes with warfarin. It's because we know that warfarin is associated with significantly higher risk of bleeding, whether that's all bleeding, but especially intracranial bleeding compared to Eliquis, for example. The other thing that I think is important to note is that the way that we use Xarelto 2.5 BID, the whole pathophysiology, or I would say pharmacology behind Xarelto 2.5 BID is different than the pharmacology behind 10 and even 20 milligrams of Xarelto. If you take a look at the pharmacology of 2.5 BID of Xarelto, it's more as an even antiplatelet rather than a full antithrombotic. It's not that we're just using it, to give us a little bit more antithrombotic. It's more on the antiplatelet side. So I agree with you that I don't think that it really refutes Compass or Voyager. I think it answers a completely different question than Compass and Voyager.
Great. Why do you think there's such a difference between the direct thrombin inhibitors and the anti-10A, just even of themselves? One is the vitamin K, you can argue, is based on patient's INR. The anti-10A is kind of one dose fits all versus the direct thrombin inhibitors are more weight-based. Do you think that's why they have, or maybe you have some other ideas as to why they had better outcomes?
Yeah, that's a really good question. And I mean, if you take a look at the number of individuals on direct thrombin inhibitors in the study, it's overall was quite low, because I think that, when dabigatran became available, soon thereafter, Xarelto became available. And if you take a look at Xarelto, compared to dabigatran, bleeding risk is lower. It's once a day pill. You worry a little bit less with things like renal function and bleeding as well too. So I think the uptake of dabigatran probably was pretty low. So I think that that's why we're really seeing a difference. I'm not sure whether it has to do more with mechanistic issues, but my guess is that we're really underpowered here to understand the true difference between things like direct thrombin inhibitors and factor 10A. I think that what we're really most powered to do here is understand the difference between vitamin K antagonists and probably everything else. And the interesting part is that I'll just tell you that the reason the study even came about, because when we took a look at VSGNE data with all comers, the claudicants are the ones that had the worst outcomes, actually. And in that study, the vast majority were vitamin K antagonists. And so we got really concerned about why is it the claudicants that had the worst outcomes? And this is why we did the current study with larger numbers and more individuals as well. But there is certainly, I think, a large part has to do with technical factors, would be my guess, that we can't just tease out specifically from this study that really has to do with the difference in outcomes here. I think the issue with mortality is that individuals who need anticoagulants in general are just sicker, and we're not able to get those confounders fully controlled for with all of our weighting that we do with other variables. I think that's what I don't think that it's really associated with one is better than the other in terms of all-cause mortality, or that apixaban or rivaroxaban are worse than dabigatran. I think the issue is that those people are just sicker, and we can't find those control for all those variables there.
Yeah, and I'll just weigh into great points, Stan. And I mean, you always wonder if there's like a class effect versus other, right? And you touch on technical, and of course there are patient level variables that drive these outcomes. And I'm sure some of these we just can't capture despite, our best efforts for, adjustment and whatnot. But, in at least in the cardiac data for AFib, and the reason why apixaban and Xarelto for that matter are so universally prescribed for atrial fibrillation is because the data just shows that they're superior to warfarin. Warfarin for patients who have an indication for stroke prevention in AFib, they bleed more on warfarin, and their outcomes are much poorer compared to the DOACs. Interestingly, for direct thrombin inhibitors, at least like in the coronary space, we of course don't really use that very much, and I think that is reflected in the VQI data as well. But typically, we've sort of strayed away from direct thrombin inhibitors ourselves, whether it has to do with AFib, cardiovascular disease, or valve disease.
Great points. I think there's time for maybe one more question, and I see one here, Dr. Schermerhorn. How did the group with the pre-op anticoagulation do for patency? Was there a difference in the ones versus the newcomers?
Yes. So I think that this is where, again, the hypothesis that this is all due to technical factors come in, because if you take those who were on pre-procedure anticoagulation, their patency rates really were no different with or without anticoagulation. It's those who are newly started on anticoagulation do the worst. And so, again, I think it's the technical factors, but I think the issue here is, again, Xarelto 2.5 BID is probably enough, and I think that the other thing that's really important here is if you take a look at we did some work with antiplatelet agents in this study as well too. Those patients who were not discharged on antiplatelet agents, and there were a bunch actually, did the worst. So it's really important, I think. I'm not a proceduralist, but I think from my standpoint as a researcher, I think what this really suggests is that antiplatelet therapy and PAD is really, really important. And it's way more important than anticoagulant therapy, no matter what the technical success is, whether it is or it is not technically successful.
I think those are great points. I'll maybe just ask one last question, because you had brought up cost earlier in terms of drugs, and of course up in Canada it's a different system, so I don't maybe this is irrelevant, but from a socioeconomic point of view, warfarin's cheaper.
Yeah,
warfarin's cheaper. So when we're looking at our deserving types of populations and their ability, is warfarin better than or better than nothing, if that's their choice, if they're not able to afford? Again, this may be only a relevant question to Canadian healthcare, but maybe your thoughts on that.
So that's a really good question. I mean, WAVE trial was very negative in stable PAD population. There have been smaller trials looking at this sort of random, INR of 1.5 to 1.8. That was a negative trial as well. From the US population, I'm sure that we all see a lot of the Janssen reps in our practice. But I will tell you honestly that they've gotten a lot better from the socioeconomic status about trying to get these drugs out there. And there are a lot of programs, and I've been pretty successful from the medication assistance point of view of getting these drugs approved. So the answer to that question is, I think that if we really want to do best for our patients, we shouldn't be using warfarin probably at almost, unless there is another indication.
Add to that, I think that's a great question, and relevant to left atrial appendage closure as well. There's data in the space that people have looked at longitudinally over time. What are the costs and healthcare burdens imposed for patients who are on long-term warfarin, who intermittently have to discontinue their anticoagulation or end up with bleeding complications? Because I think there's, depending on the time frame that you look at, and I think there are a lot of challenges obviously to these type of studies where you're trying to more or less get a sum total, if you will, of what the downstream cost implications are compared to like a DOAC, where perhaps bleeding compared to warfarin might be much less, and the healthcare implications of a ER visit or a hospitalization for GI bleed, and then subsequent testing like endoscopy that comes with that. But it's definitely relevant to a number of other areas, both, of course, vascular here, but also cardiac. And I'll just mention too, for patients who are post-TAVR, there are one study trial in particular, which I'm blanking on the name of, that looked at DOAC therapy post-TAVR, because people would think that, either warfarin or any sort of anticoagulant after a valve replacement would be beneficial. That's what we do for mitral valves. We have patients who have mechanical valves on long-term Coumadin. This particular trial was stopped prematurely due to harm for patients with DOAC. So, that just belies the fact that, in our minds, I think we often say, well, it seems like anticoagulant, something more potent than aspirin or a P2Y12 would be better. And I think across very different patient populations, consistently, it's shown to perhaps be harmful. So.
Well, thank you very much. Great to have some different perspectives from vascular medicine and from a cardiologist joining us this evening. So thank you. We're going to move into our second article, and we'll turn it over to our sponsoring faculty to go over the introduction.
Good evening. My name is Fanny Alixon. I will be introducing the next article. Let me just share my screen. Can everyone see this? All right. So just to introduce the topic, we're going to be discussing degenerative aneurysms of the descending thoracic aorta, which I will be abbreviating as DTA in the next few slides. And we're mainly going to be focusing on fusiform and saccular aneurysms, otherwise classified as true aneurysms, as opposed to aneurysms that are derived from an aortic dissection or a pseudoaneurysm, as illustrated at the bottom. A quick word on the epidemiology of descending thoracic aneurysms versus AAAs. I think it's a little bit different, and here we're really focusing on the thoracic aorta. The patients affected by descending thoracic aneurysms are typically a little bit younger, although it remains a disease of the elderly. And the male to female ratio is a lot different than in AAA, where the male to female ratio is 6:1, whereas in the thoracic aorta, it's 1.7:1. So there's a lot more women that are proportionally affected. And to keep in mind also that their aorta is about 10% smaller than male aortas. A lot of the data we have is based on this retrospective review from 2002, where they had a prospectively built database where they looked at 721 patients with descending thoracic aortic aneurysm. There's no mention of aneurysm morphology in this database. And this is kind of one of the mainly cited papers where the male sex was found to provide some relative protection to rupture and aneurysm growth, and where the suggestion comes from that we should watch women more closely, potentially because of their proportional aneurysm size relative to their overall body size. So this is kind of where this comes from. If we look at morphology, which is going to be discussed in this paper, saccular versus fusiform aneurysms, most of the data we have is regarding fusiform aneurysms. We know that aneurysms greater than 6 centimeters in the descending thoracic aorta are associated with an increased risk of aortic-related adverse events and aortic-related mortality. And once you pass the 6 centimeter threshold, as you can see in the graph below, which is from the same article I just cited, your risk of rupture increases 27-fold. And so that size threshold is important to keep in mind. When it comes to growth rate, typically aneurysms in the thoracic aorta grow by 0.1 to 0.2 centimeters a year. There's very little data that actually exists regarding the rapid aneurysm expansion and what is actually considered accelerated growth. We typically just use 5 millimeters, or some people are more conservative and use 1 centimeter a year. Overall, however, the behavior of those aneurysms and their growth patterns, the natural history, as well as their rupture risk, especially when associated with the saccular morphology, is somewhat poorly understood. We believe that it's at higher risk of rupture than fusiform aneurysms because of the shape of the aneurysm, which inherently increases the wall stress, but there's really truly minimal evidence to support this. And despite this, most saccular aneurysms will undergo repair, but there's no definitive size threshold that's been agreed upon. So there's the SVS that has recommendations for repair. Again, the size threshold is 5.5, which will be similar in the ACC AHA guidelines that I'll present in the next slide. But there's really no specifications regarding the morphology of the aneurysms. And in the ACC guidelines, they simply state that there should be a lower size threshold for saccular morphology, but there's no additional consensus or size that is being discussed. So all in all, I think the morphology, as well as data regarding descending thoracic aneurysm management in women, it is poorly understood, or at least there's not a lot of data to support this, hence the paper that we will be discussing today. And I will hand it over to Michaela to discuss the paper itself.
Okay, can you see my slides? Hi, everyone. My name is Michaela Lowenkamp. I'm one of the fourth-year integrated vascular surgery residents at UPMC. And today I will be discussing clinical presentation, outcomes, and threshold for repair by sex in degenerative saccular versus fusiform aneurysms in the descending thoracic aorta. It was published this month. It's a retrospective cohort study that utilized VQI data. Their aim was to assess the necessity of morphology and sex-specific diameter thresholds for TVAR for thoracic aortic aneurysms and examine differences in presentation, treatment, and outcomes following TVAR for saccular versus fusiform aneurysms. As mentioned, it was a VQI study, so they utilized VQI patients that underwent TVAR from January of 2012 to April of 2022. Patients were excluded if the TVAR was done for aortic dissections, traumatic injuries, non-degenerative aneurysms, or aneurysms that involved the ascending or aortic arch. That left them with about 2,000 patients who underwent TVAR for degenerative thoracic aortic aneurysms. 655 were done for an emergent or urgent indication, such as a symptomatic or ruptured aneurysm. About 37% of this cohort had saccular aneurysms. They had 1,352 patients that underwent TVAR electively, and about 35% of that cohort was done for saccular aneurysms. In the emergent urgent cohort, they found that saccular aneurysms were treated at a smaller diameter in comparison to the fusiform cohort. They found that saccular aneurysms were also less likely to have undergone prior aortic surgery. They found that saccular aneurysms more frequently underwent emergent or urgent TVAR below the threshold in both females and males. And that among the ruptures, females with saccular aneurysms were more frequently treated below the current aortic diameter threshold compared to fusiform morphology. In their linear regression model, they found that female sex was significantly associated with lower preoperative diameter in the fusiform aneurysms. However, this was not the case in the saccular cohort. Their outcomes of the TVARs following an emergent or urgent indication found that compared to fusiform aneurysms, the saccular aneurysms had similar rates of perioperative mortality and 5-year mortality. They also had similar rates of major complications in the postoperative period, which included cardio or pulmonary complications, stroke, lower extremity ischemia, acute renal failure, spinal cord ischemia, or intestinal ischemia. Looking at the elective cohort, they found that the saccular aneurysms were less likely to be on a beta blocker, although baseline perioperative characteristics were similar between the two groups other than this finding. Again, these aneurysms underwent repair at a smaller diameter. They were less likely to have undergone prior aortic surgery. They had a less extensive zone coverage, and they had a more proximal landing zone. The outcomes revealed no significant difference in perioperative mortality in comparison to the fusiform and saccular cohorts. But they did find that saccular aneurysms had a lower rate of postoperative spinal cord ischemia, which they hypothesized could be explained by the shorter zone coverage. Overall outcomes found that the saccular aneurysms were associated with higher long-term mortality compared to the fusiform, with 5-year mortality at 23% versus 17%, and a hazard ratio of 1.53. So to summarize, saccular aneurysms underwent smaller or repair at smaller aortic diameters in comparison to the fusiform cohort. In the saccular aneurysms that underwent emergent or urgent repair, they found that females were had over a 3-fold risk of repair below the threshold of 50 millimeters. Males were twice as likely to be repaired below the elective 55 millimeter diameter. Females underwent emergent urgent TEVAR for smaller aortic diameters for fusiform aneurysms in comparison to their male counterparts. And saccular aneurysms had lower perioperative spinal cord ischemia, but a higher all-cause 5-year mortality in comparison to the fusiform cohort. TEVAR for symptomatic fusiform aneurysms had higher rates of perioperative mortality compared to the elective TEVAR, which was not the case for the saccular cohort. The key takeaways from this paper is that it supports the current guidelines that saccular aneurysms should be repaired at smaller diameters. It also reinforces that saccular aneurysms do require very close clinical surveillance and possibly earlier repair. And also demonstrates that there's a paucity of data regarding sex-specific diameter treatment threshold of thoracic aneurysms, and their data may indicate necessity for sex-specific threshold for treatments of fusiform aneurysms, as they found in their models that female sex was associated with a smaller aneurysm diameter at the time of both elective and non-elective repair of the fusiform aneurysms. No study is without limitations, and I think primarily the limitations of this study are inherent to the VQI data. As we all know, there's a great variability of data collection. In this particular study, the data was limited to surgical patients, so those that underwent TEVAR repair, and they were unable to evaluate long-term reinterventions and ruptures in this cohort. But overall, it was a great paper and highlighted the need for further studies and data on this topic. Thank you.
Great job, Dr. Lowenkamp, and this was a great review. And I want to congratulate also Dr. Schemerhorn for another great study. Please just write the questions you have on the meeting chat. But the first question I had for Dr. Schemerhorn is that what size are you using in your practice for saccular aneurysms in elective? Because obviously the paper doesn't answer that. Just and same as the guidelines, just say that you should you can fix it at the lower size. But what is your magic number?
Yeah, great question. And I don't think there is a magic number, but what you can do, and this goes back to when we were looking at differences between men and women with AAA repair. We looked at the proportion of repairs that were done for a rupture versus intact. And, for men at 5.5 centimeters, it was about 11 or 12%. And to get that same level in women, it was 4.9. So that sort of confirmed what we've all been doing, operating earlier on women. And I think you could apply that same philosophy to that figure 1 and say that, we had to combine to get smooth curves. We combined the ruptures and the symptomatic patients together. But if you want to get those numbers to be sort of the same proportion of emergent repairs for the fusiform as the saccular, then you would drop the diameter for men down to about 4 centimeters and for women probably down to about 3.5 if you just kind of follow the curve over to the left where it crosses the line of 5.5 or 5.0 to get from the fusiform to the saccular. So maybe something like that would be appropriate, but I don't know. I think anybody else might have at least as good an idea as I do.
And it's interesting because in the range, I mean, there are people who are fixing them based on the study at 4.4, and that's, I mean, 25 percentile. So I mean, that's, I mean, I guess we're following that as a society. So for Dr. Rastoger, Dr. Schermerhorn, one of the parts that I found really interesting on the study is that saccular aneurysms are almost a marker of survival on the elective setting. I mean, that difference on 5-year mortality. I mean, what I know it, and you allude on your paper that you cannot answer a causality, but why do you think that happened?
Thank you for the question. That's again, it's very hard to answer. It may have been due to some pathophysiological reason that we are unable to distinguish within the data set. Currently, we're stating that all these patients were degenerative aneurysms, but we don't know what makes a saccular aneurysm. So yeah, it's still an answer that needs to be a question that needs to be answered in the future.
Because I mean, that morphology is sometimes associated with mycotic aneurysms, and it may be tough for you to lose it. Like, I mean, I'm sure you exclude those on like if there was a mycotic nature from the database, right?
In principle, yes. That was in principle that was what we did. We really only included degenerative aneurysms. But as we know, with these large registries, there may be mistakes in them.
We have a question. Do you consider PAUs a saccular aneurysm? And if not, what size do you fix them?
That's another one that's not based on a whole lot of data. For me, for a PAU, certainly if they're symptomatic, but if they're asymptomatic, then I'll use 2 centimeter diameter or a 1 centimeter depth. And I think that's more consensus than data driven. But yeah, that's sort of what we use.
And did you look at outcomes based on size? Like at what size was the aneurysm repair? Because I didn't see that. Did you stratify it by size? Like if there was any difference?
Phenomena, do you want
to? Sorry, I didn't really get the question.
Yeah, so if you look at in your database, if there was any difference in outcomes based on the size of the aneurysm.
We didn't look at that for this paper. So we did not look at that for now.
Okay. And I mean, the other interesting part is that how the patients with saccular aneurysms have in the elective setting less SCI, so less spinal ischemia. Probably is based on the area covered. But do you look at the use of spinal drain on these? Like
we did not look at that for now. Yeah, we really think it only has to do with the coverage for now, and whether it has to do with if there's a longer part of the area that is diseased. Whether it has to do with the disease or really with the coverage is still to be determined. But we did not elucidate for preoperative spinal drainage, no.
And one question to Dr. Schermerhorn. So if we want to answer the question on size for saccular aneurysms, I mean, how can we do? I mean, we're going to need to have the non-treated cohort, right? So is it going to need to be in an institutional database, or how can we answer
that? Yeah, I don't, that's going to be tough with just, it'd have to be a multi-institutional effort where you go back and search for all the people that you didn't operate on and have good follow-up with them. That would be tough. So I don't know. And I doubt this is something that's going to make it to a randomized trial. So I think we're going to have to look at data like these and make our best guess. And I was looking again at that figure, and I was probably undercalling it a little bit. It's probably closer to like 4.5 or 4.3, something like that for men, and a little bit less than that for women. But that's about the best that I can make out of it. And I don't know of a great way to get better data.
There's one question regarding the coverage. So was there more coverage in the fusiform thoracic aneurysms compared to saccular? And yeah, and you answered the relationship to cord ischemia.
Yes, we did see more coverage indeed. There was a longer length of coverage in those with a fusiform aneurysm.
And unfortunately, we can't do coverage length, so we have to do zones to sort of approximate that. But it seemed to still suggest the same thing.
And there's a comment by Dr. Demusio that thankfully TVAR devices are far smaller these days, so they can apply this most excellent technology to many patients, and it's a game changer in vascular surgery.
Yeah, absolutely.
And
he was lamenting the lack of, that we didn't publish sooner so that he could do more thoracotomies early on before TVAR came around.
And the new AHA guidelines, do you agree with those, like doing 5.5 for thoracic aneurysms?
I was a co-author on the
No, so you agree.
paper side. So of course I agree.
Perfect.
Well, thank you for all of the discussion, and it's so great to have the authors here to be able to answer some of the questions, think about things, where we are now and where we're going. So we appreciate everybody's participation. Happy holidays to those of you that celebrate. We will see you all January 10th for the 2024 inaugural January JVS Online Journal Club. Thank you and have a great night.
Thank you.
Thanks so much.
Bye-bye.